So let's move on now with some more dental problems. These dental problems can be seen in the interceptive ortho group, which is the kind of adolescent, or it can be in adults if they don't pay attention to it when they were younger. So I kind of compile it all in this one lecture so that you can become very familiar with what the orthodontists see as dental problems, not necessarily something to do with the jaws, but something to do with the teeth as a very common thing. So you can be very familiar with this and start to notice it and maybe refer it or act onto it. So to finish the topic of canines, so we said please remember to palpate the bulge of the canines at age 10. So let's say you do nothing, or you see the patient later on in life where no one has palpated their canines and the canines are now impacted, they didn't erupt, and the patient is older. So you need to know that the canine impaction is the most common impacted tooth, second of course only to third molars, and third molars have their own issues as we know. So the second most common impacted tooth is the canine. So it's a very common thing. It's usually 2 times females than males, so see it more in ladies. And third of them are labially impacted and 2/3 are palatally. So you need to probably start seeing, if you don't see the canine erupted and you don't see it erupted buccally and there is no bulge, you can start to look in the palate to see if there's any bulge there. It occurs in around 1 to 2% of the population. So out of every 100 patients, you might see it in 1 or 2 patients. And 8% are usually bilateral. And the rest, 92%, is only unilateral. So you can see it on one side. Lower canine impactions is not as common, and very rarely we see them. Not very rarely, but much less than the upper. So what happened, or what is the cause of this canine impaction? What can it lead to? As we can see, the canines can become very aggressive if they lose track, because the root is very strong, as you know. Probably you know from the endo treatment on a canine, they're very long, they are very strong, there is a bulge for them, so it can become very aggressive. Many times it loses track, mainly if the lateral incisor is either peg-shaped or missing. So one of the theories is that lateral incisors give guidance to the canine. So that root of the lateral give guidance for the canine to come in a natural way. So over here we can see that there is a missing lateral on the right and there's a peg-shaped lateral on the left. Although the peg-shaped lateral is also kind of ectopic, didn't erupt, didn't resorb the B, still we have the canine, and the canine here is going so much mesial, almost going towards the central. So that can be a problem, and here we need to intervene. Another issue here, if it becomes very aggressive, it can really lead to the resorption of the root of the lateral. Look at this here. This is the canine and this is the lateral. It resorbed the root fully to the point that we cannot save this lateral. So it is a serious issue. We need to keep an eye on the canines all the time. So let's look at this case. This patient came to me, he was around 13-14 years old. As we can see, one side the canine is coming, and on the other side we don't have space for it. But look at it here. You can feel there is a bulge. You can see it even, that there is a bulge here. So of course we diagnosed it with x-rays, and it was lingually positioned. And the procedure usually from the ortho, so that you become familiar what to expect when you send the patient to the ortho, is that the orthodontist will decide whether they will open up space or they will extract a tooth based on the whole diagnosis and what is needed for the patient's face and space analysis and all of that. So in this case we decided that we can open up space. So we use this open coil to make room for the canine. And then once there is enough room for the canine, we do the exposure, where we send them to the surgeon so that he can open up. They will put for us a gold chain so that we can start to move the tooth where it belongs. And a little by little, the tooth will come into the arch where it belongs, and then it becomes well aligned with the rest of the teeth, and we close the space and we finish. So this is the patient before and after. So it is a procedure. I mean, it's a long thing. It took around 2 years for this to happen. So eventually we can get it, depends how far it is, but it's an exposure, it's a surgery for the patient, it's a long treatment. So if we can avoid it, that would be much better. And here is our beautiful patient with his smile. We can see here, see, if you would have palpate here, you wouldn't feel anything. So that's a red flag. That's why it was palatal. And as we see, the midline is shifted, and there is a crossbite on that tooth, and so on and so on. All of this was corrected with braces. And this is another case for another girl. She was a bit younger than him. She was around 12. And we see bilateral, the canines are impacted. Look at it. Both of them are palatal. This one is more horizontal. This doesn't have a very good prognosis, or it will be difficult for us to bring into the arch. We extracted the C's and we waited for a while, but of course we don't expect a natural correction because it has crossed even the full lateral and almost half of the central. The more it crosses, the higher it is, the worse prognosis it is, but we will always try. So we started again providing more space, and then we extracted the C's as well. We did the exposure for the canine. And we started to pull. On this side wasn't too bad, but this side was very high up. So as we expect, the right side came through, it was rotated, we corrected that, but this side we needed to re-expose again. It didn't come through, so here we moved it a little, but it needed another exposure to correct it. And here it came, this was the second exposure, and here finally it is into the arch. Unfortunately, this patient left the country, so I couldn't finish it up, but at least I was able to get the canines. Again, this took a long time, but eventually, hopefully it can happen if the canine is not ankylosed and if it is in a position where we can move it and away from the roots. The other problem we can see with the eruption of the teeth posteriorly is something called transposition, meaning one tooth will be fully replacing or erupting in the place of another tooth. So if we look at it here, we can see that this is upper central, permanent lateral, baby canine, 4, 3, and 5. So 3 and 4 has changed their position. And if we look at the x-ray, what decides whether it is transposition or not is the root position. So if the root of the canine is totally where the root of the 4 should have been, meaning the root is not mesial and the crown is just tipped distally, we call this to be transposition, a true transposition, meaning the whole bud of that tooth is distal to where it belongs. So this is a true transposition. Our options here are either to accept it and keep them transposed, or to, if it's a crowded case, we can extract the 4 and bring the canine where it belongs. Or if we want to be heroic, to orthodontically try to move the canine where it belongs, but that's not very easy, and we get the canine outside the bone and not very good. So in this case, we decided to accept it. So we moved the canine, we extracted the baby canine, and we moved the 4 mesially. So we did canine premolar substitution of a canine, and then everything was well aligned. So this is the premolar acting like a canine, and canine acting as a premolar. The only problem with that is that sometimes the palatal cusp of the 4 can show through the smile because it's more anterior. So sometimes we can reduce it a little bit so it doesn't show aesthetically in a bad way. Again, notice that her lateral is small shaped, and as we said, there is an association between canine issues and small laterals or missing laterals. So it looks like the guidance wasn't given by this lateral. That's why the canine lost its place and went distally. So these canines, as I said, they can kind of wander around and really lose their direction, and it come up with issues like this. Okay, now ectopic second molars. apart from canines, I'm sure your eyes are looking at the canines. Yes, this patient has canine issues, but apart from that, also she has ectopic second molar. And that's sometimes we see it as what we call posterior crowding, meaning there is the canine being impacted or ectopic, and it doesn't erupt normally in the mouth. Look at it here. Remember when we talked about the ectopic first molar in kids? So this happens the same with the second molar. Sometimes it gets locked under the CEJ of the first molar. And in this case, it will need our intervention. We can either surgically expose it and push it back. Sometimes the third molar is lying over the second molar, and that's the reason. So we might extract the third molar. Depending on how it presents to us, we can decide what to do. Sometimes we can extract the 7 and rely that the 8 will replace it, depending on what's happening. And the worst case scenario, if it has damaged the first molar to the point that's not a good prognosis, we can extract the first molar and have the second molar replace it and orthodontically upright it, and so on. So this is a case, the case when it was treated with braces, it was uprighted, and we can see now that the 7 was able to be corrected, although it took time, of course, but eventually we saved the 7 and we saved the 6 from further damage, and the 8s will eventually hopefully find space and erupt on their own. And there are many mechanics that can be used with an eyelet and the open coil to push the tooth back, or TADs can be put in the ramus, mini screws kind of to pull the tooth backwards, etc., etc. So these are some of the dental issues that we see, and I'll see you in the next section to talk about crowding.